Welcome to our presentation on the NICE guidelines for managing acute sore throat. We'll explore assessment criteria, treatment options, and antibiotic recommendations. Our focus will be on self-care strategies, appropriate antibiotic use, and identifying patients who may benefit from antimicrobial therapy. Prepared by Dr. I. Habash. Understanding acute sore throat is crucial. It's typically a self-limiting condition, often triggered by viral infections. Symptoms usually last around 1 week, and most people recover without antibiotics, regardless of whether the cause is bacterial or viral. Initial assessment is key. For children under 5, follow NICE guidelines on fever. Use clinical scoring tools like fever pain or Centaur to identify those who may benefit from antibiotics. Provide self-care advice on managing symptoms such as pain, fever, and dehydration. Reassessment is necessary if symptoms worsen rapidly or significantly. Consider alternative diagnoses like scarlet fever or glandular fever. Note any previous antibiotic use, as it may lead to resistant organisms. The fever pain criteria help assess the likelihood of a streptococcal infection. Scores range from 0 to 5, with higher scores indicating a greater probability. Key factors include recent fever, pus on tonsils, rapid attendance, severely inflamed tonsils, and absence of cough. The Centaur criteria also assess streptococcal infection probability. Scores range from 0 to 4, with higher scores indicating a greater likelihood. Consider tonsillar exudate, tender anterior cervical lymphadenopathy, fever history, and absence of cough. For patients with a low likelihood of benefit from antibiotics, identified by fever pain scores of 0 to 1 or Centaur scores of 0 to 2, antibiotics are not recommended. Instead, provide self-care advice and guidance on when to seek further help. Patients with moderate likelihood, indicated by fever pain scores of 2 to 3, may not need immediate antibiotics. Consider a backup prescription and advise on its use if symptoms don't improve within 3 to 5 days or worsen. For high likelihood cases, with fever pain scores of 4 to 5 or Centaur scores of 3 to 4, consider immediate antibiotics or a backup prescription with advice. Seek help if symptoms worsen rapidly or significantly. Immediate antibiotics should be offered if the patient is systemically very unwell, shows signs of serious illness, or is at high risk of complications. These factors necessitate prompt intervention. Referral to a hospital is necessary for severe systemic infections, signs of sepsis, or suppurative complications like quinsy or cellulitis. Lemierre syndrome, though rare, requires urgent care. Self-care recommendations include pain relief with paracetamol or ibuprofen, ensuring adequate hydration, and using lozenges for minor pain reduction in adults. These measures support symptom management. Evidence on self-care shows oral analgesia like aspirin, paracetamol, and diclofenac potassium is more effective than placebo. Medicated lozenges may help reduce pain, but improvements are small. Limited evidence supports other interventions. For adults, the first-choice antibiotic is phenoxymethylpenicillin. Alternatives for penicillin allergy include clarithromycin or erythromycin, especially during pregnancy. Dosage and duration vary based on individual needs. Antibiotic course length can vary. A 5-day course may suffice for symptomatic cure, while 7 days is practical for phenoxymethylpenicillin suspension. A 10-day course may increase microbiological cure chances, especially for recurrent infections. Antibiotics can shorten symptom duration by about 16 hours over 7 days. By day 7, 87% of patients are symptom-free with antibiotics, compared to 82% without. This highlights the modest benefit of antibiotics. Antibiotic dosing frequency is crucial. Evidence suggests twice-daily dosing of phenoxymethylpenicillin is as effective as 3 to 4 times daily. This supports adherence, especially for children at school, while 4 times daily is standard in studies. Safety considerations include penicillin reactions, occurring in 1 to 10% of people, with anaphylactic reactions in less than 0.05%. Antibiotic-associated diarrhea occurs in 2 to 25% of users. Erythromycin is preferred if macrolides are needed during pregnancy. Key takeaways include recognizing sore throats as self-limiting, using clinical scoring to identify antibiotic need, practicing antibiotic stewardship, and prioritizing self-care. These strategies ensure effective and responsible management.